Okay, so do you want to just stay on here? Or do
Very
you want to
good.
go to your iPad?
I think that's what I'll do. I don't know. I'll ask her.
This is Rosemary's husband. Your meeting starts 11:45, right?
Hello. I just unmuted myself. I can't hear you.
Boy. Okay,
Yeah.
now can you hear me?
Yeah, I can hear you.
Oh,
Hi,
can
I'm
you hear me? Good job. Hi. Hi. My name is Susan. What is your name?
Rosemary. and I see
Rosemary. Good.
Ann just popped in.
Oh, good to see you. Good to see you. Yes, yes, for sure.
Yeah, I don't think
Oh,
we've met
good.
before.
I have not met you. No, I've not. And what day do you go to the MSAC? I'm
I
assuming.
I used to go on Mondays. Monday.
Right. Okay. I go on Thursday. Thursdays. Day.
Okay.
Yes.
Well, I have not been able to join because of our circumstances have changed. We're doing online virtual ed with our grandson.
I see.
And so we
Yeah.
have a 5 and a 2-year-old living with us now. So
You do. How about that? Boy, you're busy, busy home then. For sure. Yeah.
educational. Yeah.
Oh boy, yeah,
Good.
you gotta do that. Yes, you bet. Oh,
So anyway, I just happened to look at my phone this morning and saw we've got a speaker, and I thought, well, this would be very informative. So
well, yeah, I thought it would be too. Yes, I joined. I joined for that reason also. Yep. That's why I joined too.
hi, Ann. Let's see, is she on or she's muted?
I did.
No, hi, Ann. I'm unmuted.
That's right.
I think I'm good. How have you been?
Good, good. It's kind of slow
And-
around here.
Have you started going back to the,
Yeah,
So-
I went like past 2 weeks, so it was nice.
oh, yeah, that would, yeah. What about you, Susan? Are you going back?
Yes, I plan to. Yes, I've been going to on Thursday is my day to go back. I've
Okay.
been going to Thursday. Yep. Please remind me of your name. Are you Elizabeth? Is that your name?
I'm Ann.
Anne. Good.
Elizabeth Ann, I go by Ann.
Okay, Anne. Very good. Nice to meet you.
Ann used to go on Mondays too.
Oh, really? I see. Good. Yes, good.
Another Monday girl.
Yes.
Okay, is that Cheryl that's popped in? And there's
I
Becky?
bet it's
Yeah.
Cheryl and
Hi.
Becky. Hi,
Rosemary, it's
Becky.
good to see you.
Yeah, I just happened to look at my phone today and thought this is going to be informative. So I'm
Yeah.
pleased that I was able to make it.
Good. I know.
Have you started going back, Becky?
Yeah, a couple weeks ago.
Well, that's good.
Yeah,
So,
it's
do
it's
we
been
have-
fine. Fully vaccinated.
Oh,
Good job.
yeah.
Yay. Woohoo. Good work. Excited. Yes.
Which one did you get?
Pfizer.
Yeah. Okay. Is there quite a few people from our Monday group going back?
Oh, how many would you say, Ann, Sandy? Maybe 10 or 12?
Yes,
Well, that's a
about
good
that.
number.
Yeah,
Yeah.
it's a good number. Did you see we're supposed to start full time in mid-May, May 17th?
yes, yes.
I saw that. Yeah.
But you still have your grandkids and taking care of
We're-
them.
Well, you were still doing virtual education too. So, yeah. So I'm still, a member and paying my membership fees, but at this point in time, I'm not gonna be able to come back.
Yeah,
So we'll have to see.
you got a big job.
Yeah, it's rewarding at times though. So is everybody been okay, I guess? And you're just getting out more now that we've been vaccinated.
Yeah.
Yeah, that helps a lot.
Mhm.
Cheryl, are you going to come back full time? Uh-oh.
She's muted.
I know we can't hear you. Oh, she's going to say, oh. I can't hear you.
Hi, Shirley.
There, surely, yes. Teal's supposed to be here also.
Are you out? Are you on? Are you on break? Okay. Good job. These are my friends that we're going to have a meeting with. We're going to do Zoom.
Nana's in school like you are, bud.
Yeah. You want to say hi? Say hello.
Cute. Hi. Hi. He's cute.
He just got out of his special reading class, so he's on lunch for about
Very,
30
very good. Yes.
Hi, guys. Can you hear me okay?
I
Now
can
Give
hear
me a
you.
wave if you can.
Yes, I can hear you. Yes.
Okay. Just we're getting a few things set up and we'll be getting started in just a minute.
No. Okay, get out of here. No, that's Nana's.
No.
You get your school
no.
iPad.
No, you go get your school iPad. You're not gonna have mine. Scoot.
Oh.
No, stop acting so shy.
Birds are busy out there. Oh. So is the squirrel. I say that quietly because
Susan, is there quite a few? Is there quite a few that's come back from the Thursday group?
well, shoot, I was expecting to have one person join this group meeting and I don't see her on. Teal is supposed to join and this meeting. And then I don't see her. So irritated she's not here.
No, I was wondering if on Thursdays, if a lot of people have started coming back from that group.
Oh, shoot. I would say about 10 people. 10
Well,
people.
those are pretty good numbers, you know.
Yeah, you're
for both
right. You're right.
Monday and Thursday.
You're right. Yes.
Considering where we're at.
With everything, you're right.
Yeah.
Mhm, you're right. Yeah.
Can you guys hear me okay right now?
I can
Yes.
hear you. Yes.
So I might just try to use my computer. Well, it's obviously going to be the visual, but we'll try and use the sound here. Send a message in the chat at any time if you can't hear. Erin will be watching to double check. So just let us know if anything gets funky, okay?
Thank you. Yes.
We'll get started here soon. We're getting everything pulled up.
Okay.
Who's that?
Oh, Linda's joined.
Okay. I think that the way that I'm sharing, it might be backwards, the PowerPoint, but Dr. Ken will give us a great presentation. So I'm not worried about the slides being backwards if they are for you.
so much for coming. I'm Dr. Schmanke. I'm one of the resident urologists at KU Medical Center. Those that don't know much about urology, we are the surgeons of the kidney, ureter, bladder, urethra, prostate, all the male genitals. And beyond that, we are medical doctors of all things urination and pee. So today, I've been asked by the School of Occupational Therapy to come and speak with you on neurogenic bladder, and specifically the role it plays in people that have multiple sclerosis. It affects a large amount of individuals that have this disease, and probably a lot of you in this room. And so I want to kind of dive into what it is, what causes it, how we can possibly treat it or fix it. And am I in the way of this screen for anybody in the room? Okay, I'm trying not to move too much. I got to stay stationary. So Zoom, I'm getting zoomed here, but so I can't move too much. Next slide. That's okay. All right. So as you are all the experts in the room here, much more of an expert than I am on the disease of multiple sclerosis, but I just want to kind of start off with some epidemiology or study of the disease. Unfortunately, there is 2.8 million people who live with MS in the entire world. Click it once. Unfortunately, the prevalence is only growing, and that's growing in every single region of this world. You name it, there is more people being diagnosed with MS every day than there has been previously. Among people with MS, it usually affects women more than men at about a 2-to-1 ratio. But that doesn't mean that there aren't many men affected. There are a lot of men affected, but 2-to-1 ratio, women to men. And the average age of diagnosis is fairly young. A lot of people, the mean age is diagnosed at 32 years. How MS occurs is fairly well understood. We've been studying this for decades, but it is still a bit incompletely understood as far as what causes it. We do know that it has to do with your immune system. It is an autoimmune disease where your own cells begin to attack this kind of fatty insulation that lives within your brain, your spinal cord. And losing this insulation is like losing the outer part of a wire, and signals will not travel as well when you lose this insulation. We typically call these plaques, and these plaques are detected on MRI. And you can see them when they're as small as 1 millimeter, or you can see them grow as big as 40 millimeters. We'll go next. This diagram kind of displays how MS can affect you. So those plaques affect you depending on where they're located within your nervous system. So a plaque could affect eye movement. It could affect vision, muscle spasticity. It could affect your balance and coordination, can cause pain, fatigue, loss of sensation in any part of your body. It can affect your bowels. It can affect your sexual function, and it can affect your bladder as well, which we call neurogenic bladder in my business. And as you know, everybody gets plaques in different areas. And so having a plaque in one area is going to affect you much differently than your neighbor with MS who has a plaque in a different area. So everybody gets a bit of a different picture with the next. So to better understand what happens to your bladder with MS, we should first start by discussing how your bladder is intended to work. So your bladder is a muscular balloon-shaped organ that sits in your pelvis. It's situated by or muscles. It is typically in a relaxed state. It collects urine from the kidneys through the ureters that then fill the bladder. What's very important is that the bladder stays relaxed while the sphincters stay tight. This is how your bladder acts as a reservoir to hold things. If your sphincter is loose, the urine may just run right through. And if your bladder is squeezing, it may try to push the urine through. So it needs to stay relaxed at the muscles of the wall, and it needs to stay tight at the sphincter to allow it to fill. As it fills, it's going to activate stretch receptors that are located in the wall. And these stretch receptors then signal to your spinal cord that we are filling. As it stretches, these receptors signal more and more. And so as you fill, it sends signals to your spinal cord to say, your bladder is starting to fill with liquid. This then makes its way up the spinal cord to the brain, where in somebody with an intact nervous system then makes the conscious decision, is this a appropriate time to urinate? You may be in a grocery store, at a party, giving a presentation about neurogenic bladder and multiple sclerosis, and you may sense, I have some liquid in my bladder. Is now a time to urinate? And you then can make a conscious and a bit of an unconscious decision. It works both ways to say, no, now would not be an appropriate time. And it sends it back down to your spinal cord, to the sacral region of the cord, and then to the bladder to say, we should hold off on squeezing right now, and we should continue to squeeze that sphincter.
I don't know if this applies, but like, sometimes it seems like, if you have a bladder issue or whatever, and then it seems like it's sensitive.
Seems like it's, so I had a question here that says, he said, it sometimes feels like your bladder.
Really sensitive, like, not now,
Yeah.
but like, in 5 seconds.
Yeah, so a
I
question.
need to go.
A question from the audience was, sometimes I have this sensation, this overwhelming, it hits all of a sudden, I have to urinate. And that's what we call bladder urgency, and it's called a bladder spasm. And we're going to discuss that further. So I'll let you know more about that. Now, as your bladder fills more and more, those stretch receptors stretch more and more, and that signal becomes more intense. And in a person who has an intact nervous system, they will then get that signal to their brain more and more, and it will become a bit overwhelming. And if you can, you'll be looking for a bathroom to go to. Eventually, even if you can't find a bathroom, it will become so intense and overwhelming that you will have an accident. This is even in normal people. All right. Now, when you make the decision to urinate, your bladder has to do two things that are very important. It will squeeze from the balloon portion, and it will loosen from the sphincter portion. And that allows a coordinated urination. Let's go to the next slide. This is a lot of the same if you're looking at this slide. It's just a different diagram. So on the left, we have a kind of a pictogram of first sensation, first desire, and strong desire. And that gives you an idea of how full your bladder is and what you're experiencing as it fills. First sensation means I feel like I have something in there. First desire means I want to get rid of it. And then strong desire means I need to go to the bathroom now. In an average bladder, you can usually hold somewhere around 300 to 500 milliliters of fluid, typically on the higher end of that, but you'll start getting more and more uncomfortable as it fills. The right side is kind of a diagram for anybody who has a background in engineering, electrical work. It shows the nerves and how they work. And so I won't dig too far into it, but you have sensory nerves that go away from the bladder that say we're filling. We have motor nerves that come back that say we are emptying. And then you have your spinal cord in between. Let's go to the next one. So what can happen in multiple sclerosis to your bladder function? That was all what should happen. But multiple sclerosis can affect your bladder depending on if your plaque is in a decent area to do it. 75%, so a majority of people with MS suffer from urinary urgency. This is what we just discussed, this compelling desire to urinate. It comes on suddenly and you have to go. That's what most people with MS will experience, up to 85%, in fact. Incontinence is an involuntary loss of urine, which we'll discuss more about, but that happens in a subset of people with urgency. And retention happens in up to half the people, and that is where you cannot urinate even though you know you've got to. Now, this study I drew this from was all done with strictly women, but that doesn't mean it doesn't translate to the male population exactly. it is hard to study male and female at the same time with urinary issues because men have this organ called a prostate that sits in the way, and it can very much complicate things, especially as we get older and it gets bigger. So one major study I found, though, was kind of alarming to me. Less than half of individuals with MS that have bladder symptoms ever visited a urologist. And just above half of them ever tried a medication to help with their urgency. We have solutions for this symptom that we can really help you with. And you kind of have to know it's out there, and you don't have to suffer from these symptoms. We can help you. So go to the next slide. What is urinary urgency? We've touched on this twice now. So I'll say it a third time, and I think it's worth saying it a third time because it is the most common symptom affecting up to 85% of people with MS. It is a sudden, compelling desire to pass urine, which is difficult to defer. I know that somebody in this room probably experiences this and know it well. It's often due to overactivity within the bladder, and that is that muscle in the wall squeezing when it's not supposed to. And some individuals can compensate for this. They can control it slightly. They can tighten their sphincters, and that can prevent that squeezing from making urine leave. But some people are unable to overcome that. And when they can't overcome the urgency and the squeezing, you will lose urine, and that's incontinence. And that can be quite life altering in terms of quality of life. It's embarrassing when it occurs. You don't want to go places because you are afraid of having an accident. But we can discuss on how we can fix that and how we can also live with it if we can't fix it. Next, please. Oh, you're good. Urinary retention. This is the other side, complete opposite. We just talked about peeing way too much. Urinary retention is not peeing enough. This is where you feel sick because you got to urinate. You're having the spasms that you would have maybe with urgency, and you know you've got urine in there, but you can't get it out. Alternatively, you can have what we call an asensate bladder. You don't know that your bladder is full and it's blown up huge and it's full of urine, but you can't even sense that it's full of urine, but you can't release it. This is something that occurs for a number of reasons, but a very specific reason people with MS can develop this is what we call detrusor sphincter dyssynergia. That's a very fancy word, very fancy phrase that basically means your sphincters and your bladder wall do not talk to each other and coordinate at all. So as your bladder squeezes, your sphincter also squeezes, and you have something squeezing against something that's squeezing, you can't get any urine out. This is in MS caused by a plaque that's located in the spinal cord. You typically won't see this when the plaque is in the brain because it has to disrupt that communication between the brain and the bladder. That's good. Next. So if you visit a urologist, what are you going to do? A urologist would probably start by getting a urine sample. We have to prove that you don't have a urinary tract infection. We also have to just see if you empty all the way. So you'll probably ask you to just void completely, we'll say, and then we'll take an ultrasound probe like you would see on a pregnant woman undergoing an exam to check the baby. We would put this on your bladder and just see if it's full or not. If it's not full, we can say, well, you appear to be emptying okay. You don't have a urinary tract infection, and then we can help treat you accordingly. Some individuals will undergo urodynamic studies. This is a pretty involved test. It's fairly minimally invasive, but it can take up to a few hours because of the setup and the duration of the study. We have you sit on a very special toilet, a very expensive toilet with all kinds of technology measuring how you urinate. We will also place a catheter in your urethra. We'll place another small sensor about the size of a spaghetti noodle in your rear end, and then we place pads in between. And we can measure, we'll fill you up with fluid. We'll measure how you tolerate getting filled. We'll then have you hold the fluid and then have you empty the fluid. And we'll see how you do all these things, because people with multiple sclerosis can have a couple things going on at a time. You don't just have urgency or retention. Some people can have a component of both. And so treating it can get pretty complicated. That's why we like to have you see a urologist if you end up having any bladder symptoms, like a majority of people with MS do. Okay. Okay, how can we treat you? We have a few specific goals to our treatments. These goals include, well, first let me start by saying we have a few considerations that we take into account. First is your pattern of dysfunction. This would be, are you retaining or are you urgent? Then, what is the extent of your neurological disabilities and limits? Are you somebody who can ambulate and walk without help? Can you use your hands? How is your dexterity? Can you swallow? Can you take pills? All of these things can be affected in different ways. And if you can't swallow, we aren't going to give you oral medications. If you don't have great use of your hands, we're probably not going to ask you to catheterize yourself. So all of these things also count. Disease course, as you know more than I do, you can have relapsing and remitting MS. You can have progressive MS. These things do matter when we choose our treatments. And then patient expectations. Some people would rather die than have a catheter. And we have to take that into account. And we have to know exactly kind of what would make you happy and what is acceptable to you. So that's expectations. So our goals of treatment are twofold. We want to improve your symptoms and your quality of life. That's fairly obvious. Number two is we want to protect your kidneys. You only get two. And when you have issues with your bladder, like you get with MS, they tend to fail at the same time if you fail. So if we can keep you emptying in a safe way, we can keep your kidneys working, and we can prevent you from eventually having to require something like dialysis to get rid of all the toxins that your urine typically gets rid of. You can go next slide. So there's a number of treatments. I'll discuss them all as we go through them. This is kind of an overview, so you can go next. First is behavioral modifications. This is things that you could do as soon as you leave this talk. You could go home and you could try these things right away without a prescription, without having to see a doctor. Changes you can make today. This would be timed fluid intake. This simply means timing how you drink. If you know that you're going to run to the grocery store to pick up groceries and you're going to have urgency while you're there, you cannot drink fluid before you go. Obviously, you have to keep hydrated, but you can time how you take that hydration in. If you're somebody that urinates all night long and you're up all night, try not drinking at the last 2 hours of the day, and don't go to bed with a full bladder. Double voiding is similar, just meaning when you do urinate, sit there for another minute and see if you have anything else, anything left in the tank, and get completely empty. Having a completely empty bladder will be very helpful at fighting the urgency because it'll have less stretch receptors firing as it's empty. Timed voiding is where you set an alarm on your phone, have it go off every 2-3 hours. And when it goes off, whether you need to urinate or not, you go ahead and do it. You give it a try. This again, following the same principle of keeping your bladder empty. Pelvic floor muscle therapy. This goes to our therapy friends. It is, granted in MS, there are limited studies. We typically use it a lot in people with overactive bladder, which is when your bladder is squeezing too much without a real known reason. But it is shown to help in some individuals. And so we always recommend when we do pelvic floor physical therapy to work with a therapist who's good at it and who's been trained in it, rather than say going to YouTube and looking up Kegel exercises and going from there. Although if that's what you have, it's better than nothing.
Do you have a feel for how long it takes for liquid to get through your system?
I was asked if I have a feel of how long it takes for liquid to get through your system. That would depend on how hydrated or dehydrated you are. It also, your kidneys are filtering blood. And so it's hard to say. I mean, your blood volume, what portion of it is due to the liquid you drank 5 minutes ago? What portion of it is due to the liquid you drank 5 hours ago? So it's tough to say. And so it also, and it depends. You have hormones like antidiuretic hormone that prevents you from urinating when you need to hold on to urine. And so it really is a tough question to answer. It's a good one though. Hope I didn't disappoint you with that answer. Avoidance or moderation of bladder stimulants or diuretics. Stimulants are things like alcohol or coffee, These things will activate the bladder more. Energy drinks. Diuretics are, it's a fancy word for things that will cause you to urinate quicker. Coffee and alcohol are well-known diuretics that will cause you to urinate more frequently. So if you can avoid some of these things, the more you can avoid them, the better you'll be. Constipation. Your bowels and your bladder are so tightly linked to each other. And so if you are constipated, you're activating a lot of those same nerves that are activating the bladder. On top of that, if you have a rectum that is very full of stool, it is going to press into the bladder a bit, and you will then have less capacity to hold and more stretch receptors going off, resulting in more urgency. Of course, you should always review your medications with your doctors that you see. You may be taking medications that you don't know cause you to have urinary issues. You may be able to take them at different times. Some people are taking diuretics at nighttime. That's not a great idea because you'll wake up all night to urinate. Take them in the morning instead. These are kind of little tips and tricks that your doctor can help you through. And then get assistance when you need it. So if you are somebody who can't ambulate well and you need help to get to the bathroom, find some help to do that. Same thing as we mentioned with catheterizations, have somebody help you catheterize if you need it. Have somebody help you with a pill box if you have memory issues. These kind of things are, don't do it alone, load the boat, as we say. Go next. Okay, for those that have issues with incontinence, here's a few options for you. These are not going to make your incontinence go away at all. This is just to manage with it. So there's other treatments that can help your incontinence get better, but this is a good place to start because you can do this today, essentially. Disposable underwear. This is a lot of times, some people call these diapers, some people call them Depends. Depend is a brand name. These are essentially underwear that you don't have to feel bad about when you throw it away at the end of the day. You can also, some people that have very bad incontinence will line that with an additional pad or liner. People with not bad incontinence can just go with the liner itself. And these things are just absorbents to help gather the urine rather than have your clothes get soaked. There are kind of gender or sex specific options as well. So men can use a condom catheter. This is what it sounds like. It looks like a condom. It goes over your penis and it's held in place with some adhesive, and it's connected on the end to a tube that goes to a bag. This is like catheterizing, but you don't have to put anything in. So it's much more comfortable. Some men think it's less comfortable, and some men have trouble with it falling off. And so it has to be something that's right for you, but for some men, it's the best choice. So luckily, women now have a choice in that same realm called a Pure Wick. This came out in the last couple of years, and it's gaining steam currently. It's kind of tough getting insurance to cover it for some people at times. It's kind of been hit and miss there, but it doesn't go in like a catheter does. It stays on the outside. You place it between the labia and it wicks the urine up a suction system and into a canister. This is not a great option for women on the go. You don't take this to the gym. You don't take it with you when you go to the store or at work. This is something that you typically use when you're in bed. Which it can be great for overnight. It can be great for people who are not mobile because it can save you from having a soaked sheet, soaked clothes. And when you have soaked skin, your skin breaks down. And that's also a whole nother issue. So staying dry down there is very important. Next. Okay. This is now things that we can do to fix your problems. Oral medication seems to be I'm going to take this from least invasive to most invasive. Least invasive oral medications. These are a couple different classes of medications will work, but the two that we use frequently for overactive bladder specifically, and there's less studies for people with MS, but we still find that there are some that show it's worthwhile, is anticholinergics, which are medications that bind to muscarinic receptors in the wall of the bladder, and they basically calm the bladder walls down. The muscarinic receptors are responsible for the squeezing, and if you block those receptors, you don't squeeze. So your bladder tends to be relaxed. We call them bladder relaxing medications. There are numerous, about 10 or so different medications that do this. There are a couple that I would recommend specifically for people with MS. And so this is kind of coming from a urologist perspective. And these are medications that are given frequently in the family medicine office, maybe by somebody that doesn't have as much expertise in this, but knows enough. And oftentimes you'll see like oxybutynin is a drug that's used. Some of you may be taking it. It's a good drug and it works well, but Some drugs that are better in this class would be trospium. The way this drug is formed, it's got this quaternary amine structure, a lot of fancy words. That just means it doesn't cross your blood-brain barrier and it doesn't get into your brain. When it doesn't get into your brain, it causes less issues with other neurologic symptoms, which sometimes you already have enough of and you're trying to fight those. And so adding another layer of that, it's not good. Darafenacin is another one that's fairly good for people with multiple sclerosis or neurogenic bladder.
What about, like, how much you take, how much can you take of any of the drug?
Okay, we have a question from the audience saying, how much, what dose should you take of these drugs?
Well, I gotta take one pill for it right now.
Yeah. So for example, should you be taking one pill? Should you be taking a pill 3 times a day?
Yeah.
It depends a lot on what you're taking. So you have extended release formula pills that you take once a day. You have pills that are not extended release, and you'll take those up to 3 times a day. And it depends. There is 7 to 10 different antimuscarinic, anticholinergic medications, and each of them is dosed a little bit differently. So I can't answer it specifically, but it's something you should talk about with your doctor.
Yeah.
Side effects of this drug, it dries out anything that can be dried out essentially. So frequently people complain of dry eyes, dry mouth, constipation. And these things can all be fixed and tolerated with, mouth sprays, eye drops, stool softeners. So this shouldn't be something that prevents you from taking it. But if you have a really hard time with constipation, for example, it may not be the best drug of choice. Beta-3 agonist, it works in a very similar way. I won't go into a lot of detail. Consider it the same drug for your perspective. This is mirabegron, and a new one that came out is vibegron. These ones have less side effects, so we do prefer them, but oftentimes they cost more. And so you have to kind of talk with your doctor and with your insurance and see if you can get on these drugs. They have less of that drying side effect than the other ones. So for people with constipation, this could be a better move for you. It will potentially cause high blood pressure, headaches. So if you have really high blood pressure, it is contraindicated. Does that make sense? Catheterization. This is great for people that retain urine and can't urinate on their own. It's also good for people with urgency. You can help with urgency too, because it can keep your bladder in that empty state. You have 3 different kinds, but I'll talk about the third later. You have a indwelling catheter. This is a catheter that you put in and it stays in. Stays in for 30 days. Typically, we change it once a month. It stays in because it's got a little balloon on the end, and that balloon fills with water, and then it holds it in place. If you were to pull it, it would catch. And so that little fluid-filled balloon, I would point at it, but I don't want to lose the people on the Zoom call. It will keep it in your bladder. Now, there are some issues with having a catheter in place. It puts you at a higher risk of a urinary tract infection. It also, especially men, places you at risk for what we call urethral erosion, which is kind of a breakdown of that urethra. For that reason, we like clean intermittent catheterization better. This is what we call CIC, and it is a catheterizing form where you do not keep it in. You place it just long enough to get the urine out, and then you pull it out. There's no balloon on the end. And you can do this several times a day. Typically people do it, anywhere from every few hours, maybe 3, 4, or 5 times a day, depending on how your doctor wants you to urinate, how big your bladder is, etc. And both of these, as I said, they can help improve your emptying over time, specifically CIC. Where do you put them is a question I just received. They both go in your urethra. So men, it goes through the tip of the penis, and women, it goes in the urethra, which is where you pee from.
Where do you put the bag?
Where does the bag go is another question. The bag at night, frequently people use a bigger bag so they don't have to change it, and that can hang on the side of your bed, etc. Now, if you're an active individual, you can get a leg bag, and this is something that straps with rubber bands to your leg, and you can change that. You have to change it a little more frequently. It won't hold as much, but it allows you to get around pretty much without issue. You see people run marathons with leg bags on. So again, like I said, with the CIC, less urinary tract infections, less genital erosion, and less stone formation in the bladder. We can do the next one. Botox injections. This is one people may not know about as much. A lot of people know about the pills and about the catheters, but Botox injection is a very effective and very well tolerated procedure. This is where we actually inject Botox into your bladder through a camera. We place the camera up the urethra. This can be done while you're awake in the office under some local sedation and local anesthesia in your bladder, or it can be done in the operating room. Now, we inject about somewhere between 15, 30 injections in the bladder wall, and this will numb the bladder from squeezing. If we dose it correctly, we can allow you to still urinate without the urgency. In some individuals who want to have a catheter in place all the time, but are still having the squeezes and the urgency, we can actually dose it higher, and we can essentially paralyze your bladder on purpose. And this is so that your bladder does not squeeze at all, and then you're dependent on a catheter. And some people find this to be very satisfying to not have that squeeze anymore. It is not permanent. It lasts for anywhere from 6 months to a year, and then you'll have to get another injection. But people really do find a lot of satisfaction with Botox when we give it. Complications would include urinary tract infections, as well as inadvertently injecting a little too much and causing your bladder to go into retention. Again, that would then have to be fixed with just some catheterization for a short period before it regained its ability to squeeze. It's not permanent when that happens. All right, you can go next. This is now neuromodulation, percutaneous tibial nerve stimulation, or PTNS. Another very unique, interesting one. You'll have to see a urologist to have this done. This is derived from ancient Chinese medicine, essentially. Much like acupuncture, there is a nerve in your leg, the tibial nerve. It connects through the nerves that upstream of it into the S3 and S4 nerves of your spinal cord. These are the nerves that control your bladder. Because of this connection, we can have you see us in clinic once a week for about 12 weeks for 30 minutes each time. And we have somebody place a needle in the tibial nerve, next to the tibial nerve, I should say. It's a very small needle. Most people would not say it is painful at all. And it sends little shocks that are not painful, but you'll feel a bit of a tingle in your foot. And these shocks retrain those nerves and actually even retrain your brain to function in a different way and to have less urgency in your bladder. This is another reason, an interesting point would be if you've ever had to really go to the bathroom and you find yourself tapping your toe. You may do that unconsciously, but you're actually activating your tibial nerve. And your body has realized over time that activating that tibial nerve kind of gives a little bit of a feedback effect to the bladder, and it can provide you a little bit of a relief in a very short period. This is kind of capitalizing on that. Not completely, but that is a bit of a connection there. And if you do this once a week for 12 weeks, you can actually retrain your bladder and your brain. And you may have to continue with maintenance therapy at a less frequent rate. That would be about once a month after that. We would have you come back for 30 minutes. People find it very relaxing. You sit there, you read your book, you listen to your podcast while you do it. It's like getting an infusion in the hospital if you've ever had that done. It's kind of similar to that. You go there and you're well taken care of. Okay, next slide.
So would that be?
Yeah.
PTNS?
PTNS.
Is what the doctor would recognize that?
Yep. Percutaneous tibial nerve stimulation. Also, I've heard it said peripheral tibial nerve stimulation. I think I've seen it written both ways in the literature, but yeah, PTNS. Yep. Sacral neuromodulation. This is the same concept, but taken to another level, even more effective. This is a surgical implant that will actually place in your buttock underneath the skin. We will connect little electrodes to those same nerves. This time it's not the tibial nerve. We go directly to the source, the S3, S4 nerves, which is where that tibial nerve connects to. And we will place a stimulator underneath your skin, and it will actually stimulate consistently all the time. Big advantage here, you don't have to go back to your doctor's office every week to get this done. Once it's in there and it's working, and it lasts for a lot of people a very long time, basically based on how long the battery lasts. which is fortunate for anybody who has this. We're actually now getting longer and longer lasting batteries, and rechargeable batteries are now entering the market. Previously, this was not a real good option for people with MS. And the main reason being, you need MRIs with MS. You frequently have to restage your MRI, your MS, I should say, for lack of a better term, by looking and seeing where the plaques are with an MRI. These, up until 2 years ago, were not MRI safe. They would overheat in an MRI machine and would break and cause burns. Now we have new models entering the market, which are actually MRI compatible, full MRI, not just head MRI, but head and spine MRI compatible. And I think we'll see more and more people be trying this with MS. In fact, I'm working on opening a study at KU. I'm in the early phases of it, of looking at this with looking at functional MRI and how this changes the brain. And so we'll study it more and more. And I think we'll see this is a very successful treatment, I predict. Okay, next. Lastly, we have more invasive surgeries. A suprapubic tube. This is kind of the third type of catheter you can get. This is a catheter that, just like the indwelling catheters, stays in. You change it once a month. However, this does not go through the urethra. It does not go, in men, it's easier to say, it doesn't go through the penis. It goes actually through your abdomen, just above your pelvic bone. You can feel that bone. We go about two finger breadths above that, and we insert this tube, and it goes directly into your bladder. The distance to your bladder, especially in a man, is much shorter this way. You can imagine changing it is much easier. It's much more comfortable. In fact, I think a big advantage of this is the better facilitation of intimacy. If you guys have partners, it's not very sexy to have a catheter in down there. So if you can have this catheter go through your abdomen instead, it can provide a much better experience in that realm. Overall, more comfortable and easier to handle, and less complications. That's a bit debatable. Really, when I say that, I mean less urethral erosion, which is kind of a dreaded complication, especially in a man. Okay. Lastly, we have much more invasive surgeries. I really don't even want to talk on this one too long. This is very last resort for anybody who has this. This would be either taking a piece of your intestine and actually augmenting or enlarging and reinforcing your bladder. For people who have a very tiny non-compliant bladder, you can actually increase the size of it. You could also actually get rid of your bladder completely, and you could refashion a new bladder with your intestines, and that bladder will then drain into a bag on your side. There's no catheterization necessary for that. You will just drain passively. In people with multiple sclerosis, this is a progressive disease at times. And in the long run, a surgery like this does allow you to have some, for lack of a better term, consistency, because as you may develop new deficits, you may, if you lose your hand dexterity, should I say, you do not have to worry about safely urinating. It will urinate into a bag. This is not something we discuss the first time you meet a urologist. This is something that we discuss, decades down the road, when you're really struggling and you're kind of at your last end, and we can do this for you to help you. So not something we see frequently. In fact, it's hardly studied in neurogenic bladders. We see it a lot. We do this for bladder cancer frequently. We'll take the bladder out. We'll give you a new bladder. We call it either a neo bladder or an ileal conduit. And that will then be the way that you urinate. But for MS, this is not something you should consider to begin with, but maybe someday. You can go to the next slide. So that is it. That's what I got for you today. I had until 12:30. We had some technical difficulties, so I went right to the end of it. I was hoping to ask you guys if you have questions. It kind of depends on who's the staff here, if they'll let you stay for any questions today. If you have any on Zoom, you can put them in the chat and I can answer them. If you have in person, you can just raise your hand. I'll call on you. And I'll leave this up here on the screen. I work here. I'm a resident at University of Kansas Health Center. That means I'm in training. I'm not a board certified urologist yet, but I am supervised by them at all times. And so if you visit KU, you can visit with our staff urologists. We have Dr. Kowalik, Dr. Griebling. These are people who have expertise in treating people with neurogenic bladder. And that's who you would see. If you call that number, you can ask for those physicians. So thank you so much for today. And I'll take questions if they allow me. Yeah.
Is your brain sending signals to yourself to you have to go to the bathroom?
Yeah, the question is
Right now.
your brain sending you signals to say, do you need to go to the bathroom right now? Yes, the signal starts in the bladder. It starts with those stretch receptors. They stretch. That sends signals to the spine, and the spine shoots that up to the brain, specifically into the pons. We call it a pontine micturition center. It's an area of the midbrain. And then that actually connects with other parts of more of the cerebral cortex where you actually make that decision.
Okay, so tell me, like, you feel like you have to go, but then you go into the bathroom and you can't go. Yeah,
that's a common experience. So what I've been asked is, what about when you feel the need to go, you go to the bathroom and you can't? That is classic urinary urgency. That is an inappropriate squeeze of your bladder. Your bladder is telling you, we need to go to the bathroom now. And that's not how your bladder is intended to work. Your bladder is intended to squeeze when the stretch receptors are firing, telling it we are full. And that is where things can go wrong with multiple sclerosis and where you have dysfunction of your bladder. And that is, you've kind of made my point by bringing that up, is that it's pathological. It's unintended. So.
Because like, I had a time where like 3 times I thought I had to go and I went to the bathroom and I couldn't go.
Sure. Anybody else have any questions?
We have 2 questions in the chat. The first is toe tapping learnable? And the second is, do meds enter the bladder or kidney over time?
Is toe tapping learnable? So no, it's not what we would recommend. It's more of a reflex of your body to do that. What is learnable is stimulating the nerve with a higher frequency of, I guess, a higher grade stimulation, which would be putting that needle in direct proximity of that tibial nerve. Just tapping your toe is kind of an unconscious thing that we'll do. But no, it's not something that will probably bring you great benefit. At least it has not been studied to my knowledge, so I can't say. The second part of the question was,
do meds enter the bladder or kidney over time?
Do medications enter the bladder or kidney over time? It depends. Every medication is different. If you're discussing the oxybutynin type meds, such as anticholinergics, antimuscarinics, if you put yourself into urinary retention by taking them, meaning you're taking doses that do not allow you to urinate safely, then yes, they can. They can, if you're holding on to too much urine and your bladder stretches, if it stretches too much, it's like a balloon when you blow it up very large for the first time, and then you take all the air out of it, and it's not the same after that. And it won't squeeze back the same. Once it stretches that far out, it does that for a long period. Just doing that once won't hurt you long term, but doing that over an extended period, months to years, it's hard to recover from that, and you can have permanent bladder issues that then end up needing catheterization. So, and taking too much of the medication can do that, but at typical doses, and when you follow with your urologist or your doctor, you don't reach those doses. It would be a bit rare. Yeah.
Can you see on the MRI if you had a problem with urology or whatever?
The question is, can you see on an MRI if you have a problem with your bladder? my research for this talk, I did find that they said plaques often do correlate, but I would not believe that a neurologist could say, I see you have a plaque here. I can tell then that you have urinary issues. It doesn't work quite that easily, no.
The neurologist can just send them to you guys.
Yeah, an appropriate time for a referral to a urologist would be when you have symptoms, or if you suspect that you are retaining urine. That would be an appropriate referral. Yeah. Anything else on the chat?
No.
Okay. Anything else in the room? Okay. Thanks so much for having me. Okay. Thank you.
Awesome. Thanks, guys.
Thanks. Thank you.